Ryan Stanton here with ACEP Frontline again today here in beautiful San Diego for Accelerate and reimbursement and coding. You know our guest here today, Dr. Jason Adler, with Logix Health, and he does a fantastic job. They have given him basically the entire conference. I think you said 8 topics plus what we're talking about today, or 8 different episodes. So a lot of action, what you talk about and what we've done throughout our time together. Of course, we first talked when we started doing the revision of the billing and coding 3 years ago. We've done some updates since then, and now diving in with the work that you do, where we are, how we can make our physicians more efficient, and also, most importantly, save time and get us paid. So appreciate you being back on the podcast.
Yes, happy to be here.
Thank you so much. I think the one thing we always have to bring up with this podcast is our often crossover with you as Adler and then Adelman, because I lit you up while we were in New York City watching The Lion King, and I thought you were saying stuff on social media and you almost cried because you don't have social media, but somehow you may have pissed us off.
Definitely didn't almost cry, and somewhere out in the world, Leon Edelman is doing what Leon does.
Yes, he does.
But we are 2 distinct people.
Yeah, we definitely have a series of jokes that go between us on that, some of which cannot be on this screen. All right, so give us a little update. Where are we now? We're 3 years in. It seems like we do a lot of talking in January with these, getting those updates. Kind of give us where we are 3 years into this experiment.
Yeah, I think at the highest level, Tony Cirillo did an outstanding job with this keynote about talking about major issues facing emergency medicine. We talked about workforce shortages. We talked about workplace violence. There's some opportunities to advocate for fair reimbursement, and really kept a holistic approach to the specialty and a really optimistic tone in talking about where we are headed. More on the granular and tactical level is the work that we are doing in the Coding Reimbursement Conference. We've, as a group, focused on having topics like the Medicare fee schedule, alternative service lines with observation, and other service lines. You got a view from the C-suite. We've got some risk reduction techniques, and the coding part of the R&C conference is really focused on the guidelines. And I think, yeah, we are 3 years in. There's lots of lessons that we've learned as it relates to being able to most appropriately and efficiently document our notes in an effective way that appropriately captures the work that we're doing.
And now you're seeing a large enough sample set. After the first year, we saw some of the tea leaves starting to read those a little bit. But now with 3 years, we're really starting to see those trends with physician documentation, how we can take advantage of those, the MDM, all those types of things. Where do you see some of the big wins that we've had in this documentation? And then we'll talk about some of the areas where we're falling a little bit short.
Sure, and the reason that we spend so much time at this conference at ACEP Accelerate is focusing on the documentation guidelines is because approximately 80 to 85% of all of a typical group RVU will come from the guidelines. Mm-hmm. That's levels 1 through 5. We know that level 1 doesn't require the skill of a physician. Level 2 is measured in the 1/100th of a percentage. It's just a very infrequent code. It is used just very infrequently. So over 80% of the RVUs of a typical practice will come from levels 3, 4, and 5. You also have critical care and procedures mixed in there, but we do spend a significant amount of time focusing on the cognitive work that we perform on a day-to-day basis and how to appropriately capture that. To your question about what we've learned over the past 3 years, it's certainly been liberating that the history and the exam are now not scored at all according to the coder, at least from the coder's lens. There are risk and quality considerations that we take into effect when we are working, but the coder is not going to be looking at the review of systems or the HPI. So the coder is just going to look for medically appropriate history and exam, and that aligns with the modern medicine we practice today. There are some other areas that are really highlighted in these guidelines that we could extrapolate that relates to emergency medicine, like the antibiotic stewardship, CT utilization, consideration of escalation of care, or having a sensitivity towards cost, high quality, low cost medicine, and social determinants of health. The areas that we've learned that are highly effective and really that are valued by the guidelines, that are often performed and not always documented, would be the independent historian, the external record review, the management discussions, the independent interpretations, and that differential diagnosis area, and then finally drilling down to the risk section, which would be the consideration of prescription drug management.
With my group, we talk about this quite a bit because we really dove into it, of course, we brought in a lot of the conversations we had, especially when we were at Kentucky ACEP, into our group, and yet we're still dealing with a lot of those. People are filling in the MDM, but not necessarily doing the appropriate attestation / interpretation that gets us credit. I reviewed the CT scan, but I independently viewed the images, and here's my interpretation of those images, whatever it may be. So kind of give us those trends nationally on where people think they are fulfilling these documentation guidelines, but are still falling short or not getting credit for it, especially if they're not getting adequate feedback from their group.
Yeah, it's really thoughtful approach, and clinician education is critically important to being successful because, to your point, some of these EHRs have off-the-shelf coding products that are embedded, and I think some clinicians might just be inclined to just click a lot of stuff, which takes us away from the patient. We don't want to be away from the patient. We want to be at the bedside, not trapped at the EHR. And we also want to appropriately capture the work we are doing. And some of those off-the-shelf tools have buttons that are really coding tools, whereby there are definitions the codes are expected to know and can follow and can manage on their own, and we don't need to document that. So maybe we'll start at the top of the clinical encounter and just drive downwards of those areas that really drive the MDM. In the beginning of the grid itself has 3 different columns. It's the complexity, it's the data, and the risk. And in the complexity section, the differential diagnosis and the comorbidities are highly supportive of the work that you do. And there's always an inbound question about I don't want to write a full differential, or I've heard there's some risk management considerations with respect to the differential, and a common way we would approach that is the following. These guidelines value the cognitive work that you perform. If you are clinically evaluating a condition or excluding a condition, that is what you would document. So in the case of a patient that has maybe potentially syncope who hits their head, maybe on a blood thinner, documenting that you are ordering a CT to evaluate for an intracerebral hematoma is a way that you could integrate your clinical work with the guidelines themselves without having, let's just say, a pre-scripted dot phrase with conditions that may or may not be worked up, which could potentially increase your risk. So the differential matters. Comorbidities are supported because there's areas of the grid that focus on management of chronic disease, and we all know that a patient who comes in with shortness of breath is more medically complex if they've got a history of lung cancer than someone that isn't. So the comorbidities are supportive as well. Drilling down one layer, and we're really just talking about the documentation-dependent areas, not the stuff the coders are going to look at on their own, would be the independent historian, anyone you assimilate information from. And this, by the way, really harmonizes with the high-quality care that we provide on a shift-by-shift basis, because you see a patient that comes in aphasic, potential stroke, you're getting last time known well from the EMS. You might look at a prescription drug monitoring program and identify if they're on a certain medication. You might end up calling a family member. You look at conversations with an independent historian, or you look at an external record review. That contributes to the care and decision-making that you are providing for that patient. That's a quality tool, and the coder will recognize that and score that appropriately. After the independent historian and the external record review are the independent interpretations, and those are just documenting a interpretation of a study that you're looking at, whether that be an EKG, a chest X-ray, or ultrasound, for example. I think most of us, if you're working at 3 in the morning and you check an EKG for a patient with chest pain, probably not getting a call from a cardiologist about poor R wave progression. Maybe you are, and if you are, that's wonderful. But in most cases, we are looking at those studies and we are interpreting them in a way that contributes to patient care. And when doing so, the coder will recognize and give you that credit. The key language is to document interpreted by me or per my independent interpretation, or something to communicate the word interpretation. Mm-hmm. The pitfall, on the other hand, is documenting something like chest X-ray reviewed, chest X-ray showed, EKG with, something that it doesn't communicate that you are the one interpreting the studies. And then after that, you've got the management discussions. I think we as a specialty do a great job of documenting our conversations with cardiology, GI, orthopedics, hospital. We document those conversations. In a physician-led team, we provide high-quality care, and there are colleagues that we work with to support that high-quality care. And in an environment where we've got prolonged extended stays, we've got pharmacists that are available, in many cases in our departments, up to and including 24/7, if not less than that. But you've got colleagues that we're working with that support the care of the patient that we are providing. I'm thinking specifically of behavioral health, pharmacy, physical therapy, occupational therapy. These are meaningful conversations that contribute to patient care. That's a specific area that are highly valued by the guidelines, often performed and not always documented. So one of the take-home points from this conference is to really capture the clinical encounter for the work that's performed. You look at a study, you would document that with the right language. You have a conversation with a pharmacist about right drug, right dose, we would document that. And that would appropriately capture the coding while effectively demonstrating the care that you provided on the medical record.
Now you mentioned, because I actually thought about you at work, thank God, because I was we have an ED pharmacist for part of the day. And then we got social work in the emergency department. Do those count as conversations that will contribute to that MDM? Because there's always that thing that says I can't review records from my own emergency department and have that contribute. Has to be an outside emergency department, outside hospital, even though our admissions in our hospital count. What about those people that live within the our ED environment, but there's still conversations we have? Because I think the ED pharmacist is a gold mine. I've probably purged more pharmacopoeia data in the last 6 months than I ever had, just because of being able to lean on Williford and all of his people. His name's not Williford, but on Will and all of his colleagues, as well as our social workers with regard to behavioral health and substance use disorders, things like that.
Yeah, those discussions are oftentimes management discussions about the care of the patient. And when those are performed and then documented, they are highly valued by the guidelines and can often be level defining. And to your point, if we were to go back in time, you and I, 10 years, and we were to be in front of an audience like Accelerate, where we've got almost 900 people here, and ask every clinician in the room to raise their hand if you have access to a pharmacist at any point during the day, maybe 15 to 25% of the people would raise their hands.
Academics, that's about it.
Yeah, and now, it's almost pervasive. And I'm intellectually curious, over the next 10 years, we could ask the same question today about PTOT, for example, and social work. I think social work we've had, but PTOT and doing these assessments of whether we're going right to SNF or maybe to accelerating the care coordination process. I wonder if over the next 5 to 10 years, there's more of those colleagues that are working with us more closely harmonizing in the emergency department. These are all treatment related, and when performed and then documented, they could be a level defining event.
Well, before March, I think that was shut down, March of 2020, I had never arranged oxygen and sent somebody home. And now I do that probably once a month, keeping somebody out of the hospital, because we can do the witnessed walk test or get them below that 88% mark, get it arranged, get it delivered to the emergency department or to their home. And to me, in those discussions, because now that's extra time that we're spending on that, which some of those social determinants of health kind of conversations as well, of those things that we do more now in the emergency department that we never did before. Because just as you mentioned, ED pharmacist wasn't there. Well, we weren't arranging oxygen for home either, and yet now we can do that and keep people out of the hospital, which right now during flu season is a big deal. For people that have a little COPD and they're on that borderline, but you don't have to put them in the hospital because then they'll have the 5 different viruses that we have. There's
walking pulse ox testing that we could do, and there's other areas that we can work with care coordination. You talked about oxygen to go home with, and now a lot of hospital systems are working with remote patient monitoring, RPM, which is like a distant way to look at vital signs and evaluate patients that go home. There is a general trend to get the right patient at the right place at the right time. It's why CMS and other agencies are allowing for telehealth extensions and more utilization of telehealth. And in the spirit of that, we are, in emergency medicine, performing more care coordination. This all rolls up to that billing guidelines in that specific category of management discussions. It wouldn't be surprising if that trend accelerates.
Let's talk a little bit, because one of the talks that you did here was with Dr. Becky Parker, talking about some of the risk, because you touched on it just a little bit. We talked about some of those dot phrases. And, I'll review some of these notes with the dot phrases, and it's, patient came in with chest pain, is acute coronary syndrome, pulmonary embolism, pneumonia, Ebola, Ebola, all these things, South Africa, swine encephalopolitis, these weird, just obscure diagnoses that you have in there. I mean, so talk about some of that risk exposure and what you're seeing that we may be doing that, cutting back on the HPI, cutting back on the exam a little bit, or the use of dot phrases or things that may increase our risk, or things that we do within the notes now, within this framework, to decrease our risk.
The talk that we had just given was focused on the relationship between risk management, coding theory, the documentation guidelines, and what harmonizes and what works apart. Because historically speaking, you would have coders on one end of the table, the risk management team on the other side of the table, and there would be opposing views on certain things. So we wanted to revisit that with this new set of guidelines that we've had for a while and just ask the question. And we came to several firm conclusions. One, there are several areas in the risk management community that they coach towards and emphasize to support risk reduction that are also heavily valued in the guidelines. One of which are the management discussions. And in this case, the management discussions that we've been talking about, the threshold for the risk management community and just good quality, it exceeds the coding threshold. That's a good thing. For the independent interpretations, that aligns fairly nicely. A lot of people will bring up the question about the differential diagnosis, so it's worth hitting on that. And it sounds a little bit repetitive, but I think it's worth it because documenting what you're doing and why and what you're not doing and why is supportive of the care that you're providing for the patient. That's it. And her and I both spent we spent a significant amount of time. Her and I both have experience. I'd written a chapter for bounce backs, and she'd done some med-mal work, and we interviewed several people in preparation for this. And with the differential diagnosis, when it's framed a certain way, there was a general consensus that this is a positive thing. The pitfall is those dot phrases that we had spoken about that really just go really far and wide and include things that aren't addressed. But the management discussions are completely aligned. The comorbidities, integrating that into the decision process are very much aligned. Your diagnosis line is very much aligned. It seems like there's a much more harmony today than there was maybe pre-2023.
Just this last week, the last shift I did before I came in, I was reviewing a note from an outside emergency department, and their medical decision-making was clearly 3 full paragraphs of dot phrase. There's just this almost pre-prepared oratory on all these things. It was actually longer than the rest of the note and all the rest of the evaluation. So it's this very long, and the challenge we get into there is to me, a personalized MDM/summary is more important because it lets me know what you did for that patient, as opposed to that global aspect of it, which is 3 paragraphs that mean nothing about that patient. And maybe touch a little bit on the importance of, say, focusing on the patient and not necessarily the volume of the information that you're putting into that MDM.
Yeah, I think with these guidelines themselves and with the way that medicine has evolved, there's a natural tendency to have a desire to reduce the volume of the note. And Annals of Emergency Medicine has a nice publication showing as the guidelines converted, they had a 50%, this particular hospital system had a 50% reduction in word count post-guideline conversion. We, as a college, focus on wellness, clinician satisfaction, high-quality care, and all of those things roll up to making very patient-centric environments, but recognizing that the notes still need to be written. There is that opportunity now to focus on that stuff or the areas of care that we provide, documented appropriately in a way that it could support the financial viability of the practice without degrading what we are doing anywhere else. So to your point about these excessive uses of templates and pre-scripted language, I don't think anyone would advocate for that. That might be a legacy process. It's hard to say. But the essence of your question, which is patient-specific information, what are you doing and why, documenting that, if you were just to grab the encounter, the way it occurred in real-time, contemporaneous patient care, I think everybody's happy.
In the first, like on my notes, the wrap-up, the first 3 sentences or so, some of them are run-on sentences, are very patient visit specific. Mm-hmm. And then there was a few sentences of legal speak at the end that kind of wrap up, ask questions, shared decision-making, all that stuff. But, I feel like that, especially in my hospital that just put in a standard note, which for most of us we were already doing, is now larger because it's pulling in just a lot of extra data. It almost seems like a VA note now. But I think we trimmed down and then now we're ballooning back up again. But it's not ballooning up because of work we're doing. It's ballooning up because of the hospital trying to pull as much stuff into that one document as possible so we're not having to go to other places. I mean, you going around and seeing what you're doing with your group, are you seeing that we're kind of now ballooning back up again, whether it's the work of the physician or not?
Yeah, haven't seen much ballooning up, though there has been an evolution over time. And I think as people get more of a muscle memory and get that cadence and flow in the way that they make their notes, update their templates, and have a good sense of what they are comfortable with, I think things should level off. Now, there is in some cases, noise from upstairs with CDI and other hospital-based initiatives where they're asking you to like start the avalanche rolling of like, oh, you got to put the right diagnosis, acute hypoxic respiratory failure, so that the inpatient team can get that stuff. We understand that. That's separate and distinct from what we are doing in our emergency departments. I think there is an opportunity to reduce the overall volume of the notes and to really focus on what we are doing. And the next phase of evolution would be the ambient listening devices and the AI scribes.
I was going to ask you about that.
Yeah, because I think, I don't want to make assumptions, but I will. You may have worked clinically at a time where we were writing with paper. And then we transitioned over to the EHR, and then we transitioned, and the notes got bigger and bigger, and then the EHRs, there might have been a time, maybe between the two, where you would pick up a phone and call like a dictation service, and then somehow a note gets written, you do the whole thing in one shot. Then we had the EHRs, and then we had some dictation software, and then now we're at the bottom of an S-shaped curve of evolution related to, we'll say, ambient listening devices and AI scribes. And that presents a whole opportunity for potential wellness and reduction of bloat, but also risk. We have to be really genuine with the way that we approach this, because as soon as we sign that chart, it becomes our work. So while it might be an efficiency tool, which there are several different products out there that are being studied, and they all seem to have a lot of assets. I don't know if it's more one of those things where you walk into a room, have a patient encounter, and then all of a sudden it just comes up with a note, you sign it and move on. You really need to engage with the platform a little bit and make it personalized to you. But in an early review, it looks like the notes are getting a little bit shorter with some of these devices.
Well, so let's talk about that, because as you mentioned, yes, that was paper. Back in the day of the T-sheet with the actual stickers to do your procedures, you'd pull them off a roll.
Oh, yeah.
Stick them on there, fill out your little square for your laceration repairs.
T-sheet to a virtual T-sheet.
Yeah, into your virtual T-sheets. And I had completely forgotten, as a young attending at University of Kentucky, of actually picking up the phone and calling a dictation and doing the dictation, and then eventually it shows up. Also, when you actually had to call for a chart, somebody would bring up a physical chart and set it on the desk.
In a shopping cart.
Yeah, well, a little baby shopping cart. But your notes may be bigger. But with that, the ambient listening devices, you're right. We're on this curve where the technology is advancing at such a fast pace, and it's being instituted into our systems at such a fast pace that it's one of those things where we're going to try to catch technology, but we may never catch AI because it's going to outpace us. There may just be not as much room for it to do. Are you seeing anything from a documentation standpoint, things that are landing with the use of some of these ambient listening devices or whatever, that physicians either aren't catching or not addressing, or even potentially the hallucinations that may be there that may put in stuff that you didn't do? I mean, are we seeing kind of this growth of just stuff slipping by? Because like the early Dragon, you fully expected in a paragraph to have 10 or 15 just completely nonsensical words in there. That the patient is here for bilateral chest cabbage. Something that was dumb. Are we seeing similar with that, or is it something that physicians need to be aware of as they start to institute these ambient listening devices?
I think the timing feels right. We're now 3 years into a new set of guidelines. A lot of many hospital systems have revamped the way that the templates are created, hopefully with the spirit of reducing the note bloat and the click fatigue. If you could imagine a system with ambient listening whereby you're wearing a lapel or have some form of mic, you go in and have a full conversation with the patient, and that gets auto-populated into, you don't have to sit in front of a microphone and say all those words. You could edit. And then for the MDM section, it might offer some suggestions, and there's variation of what exists out there. Some are better suited for the outpatient sector, some are better suited for other areas of clinical medicine. But now that we've got that muscle memory of keying in on the independent interpretations, because how is a third third-party machine expected to know what your interpretation of the EKG is. So that stuff I would think we would have to insert ourselves, or at least declare the EKG interpreted by me and validate that the language is there. But it's an efficiency tool. And I think as we have workforce shortages, we've got more delays in boarding and other things, and it seems like the supply-demand becomes more of a mismatch in the specialty. We are still hyper-optimistic about the future. And part of that optimism is that things are getting quicker with the way we assimilate information. Just imagine, for example, if you could take a Care Everywhere or some product that can absorb information from multiple different places and summarize that for you, and then you could pick out what is clinically meaningful, as opposed to all those clicks of looking at a PDMP. And I don't even know if that's possible, but I think there are efficiency gains that could be performed, and certainly some wellness gains as well.
Yeah, I think we're starting to see some of them that really do a lot of the data mining, and now with the ambient listening devices going from HPIs into some of the MDM aspect and even the diagnosis. I mean, it is just the beginning, and hopefully we as humans can catch up, because we're not typically known for being, as physicians, great at technology all the time. But how can folks, wrapped up today, we're going to get you on some social media action here. How can folks get in touch with you if they have any questions, want to dive deeper into this?
ACEP Accelerate, outstanding conference. Looking forward to next year in Orlando. My contact information is jadler@logicshealth.com. Highly responsive to email. Looking forward to the upcoming year. We've got Accelerate. We also have Scientific Assembly in Chicago. Lots of great opportunity of really the best and the brightest minds coming together and sharing our collective understanding of this topic. I really appreciate being here. Thank you very much.
Yeah, this is the third year of these programs, the Billing Coding, and the third year of Accelerate. Really grown into a great conference, 900 of our best friends and colleagues here this week here in San Diego. As mentioned, we will be next year in Orlando on the property of Disney, so pretty fantastic. Actually, a return to the roots for our PIM, the Pediatric Emergency Medicine Assembly, because most of theirs, and that's actually how I got into these conferences, was actually going to theirs and learning the ped side. But as for me, you can contact me, rstanton@acep.org, rstanton@acep.org, at EverydayMed on X. Make sure that you are subscribing to the podcast on your favorite player. Give us a 5-star review. Support us to help boost us up, and continue to listen as we expand the Frontline Network. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Ding. Quiet place, all
Yeah.
alone. Da, da, da.